So, good morning, my seniors and colleagues. This is going to be a debate on mechanical power targeted ventilation, and I'm going to be talking on the pros of mechanical power. And as we all know, this equation of mechanical power has been derived from equation of motion, which is the lung volume divided by respiratory compliance plus gas flow and airway resistance plus convective gas acceleration minus the pressure generated by the muscles. And when we sedate and paralyze, we eventually remove the pressure generated by muscles, and we are left with this. And when we modify it a little bit, then this becomes airway pressure is equal to tidal volume multiplied by respiratory elastance and plus gas flow and airway resistance. Respiratory elastance is nothing but inverse of respiratory compliance. So the tidal volume divided by the respiratory compliance is nothing but driving pressure. That's why this particular part of equation motion is driving pressure. And a little modification of mechanical equation of motion is addition of positive end expected pressure at the end. The knowledge of ventilator-induced lung injury has evolved a lot from 1970s with knowledge of barotrauma, then volley trauma, then atelectatic trauma, and now ergo trauma from 2016 onwards, which denotes the relationship between mechanical energy delivered to the respiratory system at each breath and causing ventilator-induced lung injury. In 2016, late Luciano Gettinoni et al. Formalized the concept of mechanical power with the aim to quantify the contribution of respiratory rate and positive end expiratory pressure to total power delivered by the ventilator, aggregate these variables into a single physical measure whose value might relate to the risk of ventilator-induced lung injury. That was their aim. And to develop this, what they did was they took three pressure components. That is the elastic pressure, that is the driving pressure, then resistive pressure, the difference between pleural pressure and PIP, and the static pressure, that is PEEP. So these three pressures were nothing but the force. As we know, the work done is force into displacement. Displacement was represented by tidal volume. So this force was multiplied by tidal volume. And then when entire thing was multiplied by respiratory rate, we got mechanical power in joules per minute. So it is basically a concept of unifying the pressure, non-pressure parameters and expressing them as joules per minute. In 2016, Luciano Gettinoni had presented this equation for volume control mode. This is a classical equation of mechanical power with its elastic component, resistive component, and static component. And all these components were multiplied by respiratory rate to get mechanical power in joules per minute. This equation, as we can observe, does not have gas flow. And we know gas flow is an important part of equation of motion. The reason why they did not add gas flow in the equation of mechanical power was because this equation was originally designed for volume control mode where gas flow is constant. Later on, a lot of different modifications of equations came in volume control mode as well as in pressure control mode, the extended equation, simplified equation, and surrogate equations. So basically, the classical equations required standing at the bedside, applying an inspiratory hold and measuring pleural pressure, while the surrogate equation, like Giosa equation in volume control mode and Becker's equation in pressure control mode, does not require standing at the bedside and applying a inspiratory hold. So these are various equations. Now, whether mechanical power is associated with outcomes has been explained by this study by Girin et al., where they showed that if you keep mechanical power below a threshold of 12 joules per minute, it is associated with significant improvement in survival. While Serpan Neto et al. Also showed that if driving pressure cutoff of 13 joules per minute, if you maintain and keep it below 13 joules, the mortality is lesser. But in pediatric age group, it's difficult to get such cutoffs because in children, as the age increases, the respiratory rate reduces and the tidal volume increases with age. And in fact, Martin Neighbor et al. In year 2020 demonstrated the mechanical power increasing with age. And they proposed the equation of mechanical energy where they removed the respiratory rate and normalized the tidal volume to weight of the patients and proposed that mechanical energy will not change with age. However, the important drawback is removing the respiratory rate, which is an important component of mechanical power equation. So one thing is clear that some kind of normalization is required. this particular equation by Coppola et al. Actually showed that mechanical power was not different between survivors and non-survivors. However, when it was mechanical power was normalized to respiratory compliance, it was associated with outcomes. Bhala et al. Also showed that mechanical power normalized to body weight was associated with fewer 28 days ventilator-free days. This was our study, which was published this year in January, and my guru, my mentor, Dr. Shekhar Venkatraman sir, who is in this debate on the opposite side of mechanical power, actually guided me for this particular study, which was a retrospective study on 185 children. And we actually demonstrated that when we normalize mechanical power to respiratory compliance at 1 to 4 hours as well as 24 hours, it was significantly correlating with 28 days ventilator-free days. So, monitoring mechanical power in children with lung injury on invasive mechanical ventilation can be useful tool to reduce ventilator-induced lung injury. And in children, particularly, normalizing to respiratory compliance or weight can be a good idea, and which needs larger studies for its validation. So that's my end of pros of mechanical power in invasive ventilated children. Was
This
it?
will stop. Other, do you want to continue? Yes. Can you hear me? Can you see me now?
Yes, sir.
Okay. So
Yes, sir.
Farhan has very clearly outlined why mechanical power was developed, what the different components are. Just to reiterate, I will go over some of the basics that he has covered, and then go on to offer a con view on mechanical power targeted ventilation. So, like Farhan showed, it starts with the equation of motion, and the equation of motion as written in this slide is respiratory pressure is equal to the pressure that is required to overcome elastic forces plus the pressure required to overcome resistive forces plus total PEEP. That will include the set PEEP as well as auto PEEP. Now, there is a controversy about why we should include PEEP, and Marini developed mathematical equations as to why PEEP should be included in the equation of motion, and he published that study in 1993, and that reference is given in this slide. It can also be rewritten as the trans-respiratory pressure is equal to the elastance times the delta volume, which is tidal volume, resistance times the flow, plus total PEEP, as Farhan showed you. Why add PEEP to the equation of motion? My learned opponent will discuss this in his rebuttal about the nuances of adding or not adding PEEP. I will not go further on it unless there is a question posed to me. Luciano Gattinoni in 2016 proposed that all the forces that the ventilator is using to inflate a lung does work on the lung. And therefore, we can represent the total work done by the ventilator, and he called that mechanical power. So the stress and strain on the lung, there are two types of stress and strain. One is a continuous strain, which is related to PEEP. It is constant, so there is no energy input output. It just stays constant breath to breath. But on top of that is the tidal strain. Some of the energy is dissipated to overcome surface tension and opening and closing of airways. The other one is undissipated to overcome the elasticity of the respiratory system. Below is given the complete Gattinoni equation, where you can see that the components of the equation include respiratory rate, tidal volume that is actually squared, elastance times respiratory rate, resistance and volume that is related to PEEP. Simplistically, one can think of the power calculation as equation of motion multiplied by respiratory rate with some modifications. That is the best way to understand mechanical power. So, if you take the equation of motion, we know that P elastance, that is the pressure required for elastance, is also the driving pressure. So, the first question comes up, is driving pressure by itself harmful or beneficial? Since driving pressure is related to tidal volume, is it harmful or beneficial? The ARDS network study would say 6 ml per kilo is beneficial, 12 ml per kilo is harmful, and therefore you cannot just ascertain absolute values of harm or benefit to tidal volume or driving pressure. Is pressure to overcome resistance harmful or beneficial? Is the flow rate by the ventilator to overcome resistance harmful or beneficial? In volume control ventilation, if you use constant flow inflation, Gattinoni's equation of removing flow is appropriate. But if you do not have a constant flow, but you have variable flow, but volume control ventilation, or if you have pressure control ventilation, the inspiratory flow then becomes another important factor to consider in whether they contributes to whether it contributes to stress and strain in the lung. There is an example of that, even though it has not been demonstrated by research, but by observation, premature infants that are ventilated using pressure control ventilation early on in their with the early ventilators used to be having an inspiratory flow of 4 to 10 liters per kilo per minute. And often we would see pulmonary interstitial emphysema. Whether this is a manifestation of flow causing injury to the airways, causing pulmonary interstitial emphysema, is still not very well understood. Then the other question is PEEP harmful or beneficial? I shall show you some examples of why we need to pay attention to each one of these components of whether it is harmful or beneficial. This slide shows on the right-hand side the famous Amato study showing the association between driving pressure and mortality. But he also showed that when you match patients for PEEP, then an increasing driving pressure was associated with increasing mortality. But if you match for driving pressure, but the PEEP is increased, there was no change in mortality. But if the plateau pressure was kept constant, but if you have an increase in PEEP that resulted in a decrease in driving pressure, that resulted in a decrease in mortality or increased survival. Therefore, it is a mistake to interpret Amato's study as suggesting that driving pressure is the main culprit, and just by simply reducing it, you can reduce mortality. That is a misinterpretation of Amato's study. Here is an example of two lungs, one with significant atelectasis, the other one with significant consolidation. If you apply the same level of PEEP to both, in one, it results in recruitment and not much over-distension of the normal lung. Whereas with the lung with consolidation, it will result in over-distension of the normal lung with no change in the lung volume of the consolidated lung. So the same level of PEEP, which one is beneficial, which one is injurious? Obviously, the one that causes hyperinflation is likely to be more injurious than the one that causes recruitment. There was a study done in 1970 where they estimated what would be the strain, the stress at the junction of an atelectatic region with an open region when the transpulmonary pressure was only 30 centimeters. They estimated that the actual pressure at the junction might be as high as 140 centimeters of pressure. So therefore, when we try to recruit the lung, or when we ventilate lungs that have significant atelectasis that may open and close during ventilation, the junctions may be subjected to much higher pressure than what is actually the ventilator pressures. So therefore, the distribution of the pressures in different regions of the lung may not be the same. This is another illustration of that. On the left-hand side are shown two figures. The bottom figure shows an atelectatic region in where it is near the functional residual capacity, where all the alveoli surrounding the atelectatic area are not that overdistended. On the other hand, the one on top shows significant overdistension around an atelectatic area that shows significant stress and strain when you try to open that atelectatic lung with mechanical ventilation. On the right-hand side is a very interesting study from 2011 where they showed that the alveolar shape changes with inflation pressure depending on its initial condition. For example, one is an alveolus with significant atelectasis, which will then recruit with high airway pressure. Similarly, number 4 shows alveolar wall crumpling with low pressure. With high pressure, it actually shows opening up of the alveoli. So these two extremes might represent recruitment of previously atelectatic lungs. But in the middle, it shows either change in shape or just a change in dimension, which will suggest hyperinflation. The bottom panels show where exactly with each of the shape change, the stress and strain are related. They are not related at the same location in the alveolus or in the alveolar septum. Therefore, my conclusion is each component of mechanical power, which is the equation of motion, can be beneficial. It can also be harmful. It depends on the level of support from that particular component. The total mechanical power can therefore include both beneficial parameters and harmful parameters. Therefore, my conclusion is one should not adjust ventilator settings based solely on the total mechanical power that you measure at the bedside. Thank you.
You stop your screen sharing. Thank you very much, Shekhar sir, for your presentation on the important aspects of mechanical power, which we should be careful when we are applying it in our clinical practice. And as per your talk, the driving pressure is an important aspect of the concept of ventilator-induced lung injury. And this particular landmark article by Amato et al., published in 2015, told us that the tidal volume normalized to respiratory compliance was a better approach rather than tidal volume normalized to body weight to assess for ventilator-induced lung injury. And this driving pressure was actually measured at the bedside as a difference between relative pressure and positive end expiratory pressure. But there are some problems with the concept of driving pressure. The most important is it does not take into consideration the role of PEEP. So it does not take into account at what PEEP you are calculating your driving pressure. You can have a theoretically safe driving pressure of 10 centimeters of water, but it can be harmful if you're measuring this driving pressure at a PEEP of 20 or PEEP of 0, depending upon the clinical condition. According to some purists, the PEEP has no value in equation of mechanical power because the PEEP was not originally part of equation of motion either. However, Amato et al. Also had objected to adding PEEP in the equation of mechanical power because according to them, it is a single time strain into the lung, and mechanical power by definition is a mechanical energy multiplied by respiratory rate. And rate means that same mechanical energy has to be applied at a certain rate. And PEEP is not applied at a certain rate. It is a single time event and it is not repeated at every respiratory rate. And this was nicely explained by Marini et al. In 2018 by this illustration, whereby they showed that if you apply a certain PEEP like PEEP1, you are basically introducing a certain strain in the system, which is explained here in a blue box. And when you increase the PEEP from PEEP 1 to PEEP 2, now the strain, the static strain due to the PEEP also increases, which is explained here in this red box. And on the top of this PEEP 2, when you apply a certain driving pressure, then you are basically adding the strain on the top of the static strain, which is already there at PEEP 2. And what happens is the most of the elastic inflation energy associated with PEEP transitions into the potential form. And when there is an expiration, this energy dissipates into the lung parenchyma in the form of heat energy. And that also adds into the ventilator-induced lung injury. So this is an important contribution of positive index pressure to the equation of mechanical power. Also, we know that when we add a certain PEEP into a system, we are adding a PEEP volume, and then the strain which is calculated is tidal volume plus PEEP volume divided by FRC. And end inspiratory lung volume will be away from total lung volume if you have a good healthy PEEP. But if you are applying excess amount of PEEP, then you will see that this end inspiratory lung volume is reaching towards the total lung capacity and thus exposing the lungs to chance of volume trauma. So excess amount of PEEP again increases too much of strain in the system and exposes the lung for volume trauma. That's why PP is important in the equation of mechanical power. Amato also argued, and understandably so, that it is not possible to study the impact of individual component of mechanical power. For example, if you reduce the tidal volume in order to reduce the mechanical power number and reduce the incidence of ventilator-induced lung injury, you will have to counter the atelectasis which can happen because of reducing tidal volume and minute ventilation by increasing the PEEP and by increasing the respiratory rate, and you will end up having higher mechanical power. So this brings us to the important concept of one component affecting the other component. But this is not just the problem of mechanical power. You see the same problem with driving pressure also. For example, if you are ventilating in a good lung compliance at a PEEP of 8, relative pressure of 18 with a driving pressure of 10 and a tidal volume of 6 ml per kg, and when the lung compliance is poor, you want to keep a driving pressure less than 15, you will have to reduce the tidal volume from 6 ml to 4 ml per kg. And in doing so, to counter the atelectasis trauma of lower tidal volume, you will have to increase the PEEP. And to maintain the minute ventilation, you will have to increase the respiratory rate also. So this is something which is a problem with the concept of driving pressure also. And this brings us to the important component of mechanical power, that is respiratory rate. Protti et al. Have actually demonstrated that the strain rate is also important. The strain that were safe at a lower rate become unsafe when the same strain is applied at a higher rate. So when you are applying a certain driving pressure, it is not just the driving pressure, but the rate at which the driving pressure is applied is also important factor for ventilators injury, induced lung injury, and the energy to distend the lung, to move the gas, and to keep the lung open also is important when it is multiplied by respiratory rate. So that rate is a very important factor of equation of mechanical power. Now coming to the last point, the important point which Shekhar sir was saying, that the total number of mechanical power that of joules of 12 joules or 13 joules per minute is not important, because what the individual parts of mechanical power equation are doing is important. To explain this, we can have different combinations by which mechanical power can be increased. It can be increased by increasing the PEEP, increasing the tidal volume, increasing the driving pressure, or increasing the respiratory rate. And in this particular very nicely done study on 42 healthy pigs, they achieved high mechanical power by 3 approaches: by increasing the tidal volume, respiratory rate, and PEEP. And they demonstrated that at the end of 48 hours, the histopathological changes in all the 3 strategies were very similar and indistinguishable. And they actually showed that there was no statistically significant difference amongst the groups in terms of incidence of emphysema, inflammation, vascular congestion, etc. So what it means was the over a period of time, the integrated effect of respiratory rate or higher PEEP or tidal volume is ultimately going to be the same, as long as you cross the particular number of mechanical power and cause ventilator-induced lung injury. This particular important paper by Costa et al. Actually had a very important comment in their discussion, which literally summarizes of what we are discussing. It says that high mechanical power values can have three possibilities: either a severe underlying disease in the lungs and adequate ventilator settings, severe underlying lung disease with injurious ventilator settings, and injurious ventilator settings simply without any underlying lung disease. So mechanical power has a definite role in monitoring and strategizing the care of invasively ventilated children. In children, larger studies are definitely needed to establish its role, particularly role of normalization and standardization of cutoff values for thresholds of ventilator-induced lung injury. My question to Shekhar sir finally is, do you agree, sir?
So my question back to you, Farhan, would be, do I agree to what?
Yeah. Agree to these 3 points, sir.
I think these 3 points actually support my view
Yes, sir.
that you cannot look at global mechanical power because you have to know what your mechanical ventilator settings are doing for the disease. If it is optimal, then you leave it alone. If it's not optimal, then optimize it. If you're doing only injurious ventilation, avoid it. So the global mechanical power, the absolute value doesn't tell you whether it is injurious or not. It is the individual components that are going to tell you whether they are injurious or not. So I agree with the concept of classifying patients based on this. They have one classification. We could probably come up with more classifications that are more useful.
Thank you, sir.